First, we'll take a small step into the clinical presentation of Cushing syndrome, followed by a giant leap into the workup and management. Cushing syndrome is a fancy name for the clinical signs and symptoms that arise in the setting of prolonged exposure to excess glucocorticoids. And it's sketchy, it's symbolized with an oversized cushion. Now, when I say excess glucocorticoids, I mean an inappropriate elevation in glucocorticoid levels. In other words, before the diagnosis of Cushing syndrome can be made, states of physiologic hypercortisolism, including pregnancy, severe obesity, PCOS, physiological stress, poorly controlled diabetes, and even chronic alcoholism, need to be ruled out. The best way to conceptualize the etiologies of Cushing syndrome is to categorize them by ACTH dependence. In ACTH dependent Cushing syndrome, excessive production of ACTH is the root problem. Excessive ACTH stimulates the adrenal glands to produce extra cortisol. At Sketchy, ACTH is symbolized by the action clapperboard, stimulating the adrenals to act, if you will. Approximately 80% of endogenous Cushing syndrome is of the ACTH dependent variety. Most commonly, the overproduction of ACTH occurs at the level of the pituitary gland. In this case, it's termed Cushing disease. Notice the action clapperboard coming from that pituitary shaped pack. Cushing disease is almost always caused by a pituitary adenoma hypersecreting ACTH. So we've added a plus symbol. Think of ad for adenoma. Cushing disease is by far the most common cause of ACTH dependent Cushing syndrome, accounting for 65 to 70% of all cases. ACTH dependent Cushing syndrome can also be a result of ectopic ACTH production by other non pituitary tissues, including both benign and malignant neoplasms. Small cell lung cancer is the most common culprit. So we've incorporated our cancer crab symbol into this lunar rover collecting some small cells. Cushing syndrome can also be ACTH independent. In these cases, elevated cortisol leads to low ACTH as the result of negative feedback by glucocorticoids on the hypothalamus and anterior pituitary. Approximately 20% of endogenous Cushing syndrome is ACTH independent. The most common cause of ACTH independent Cushing syndrome, and all types of Cushing syndrome for that matter, is exogenous glucocorticoid administration, which negatively feeds back on the hypothalamus and pituitary, turning that ACTH down. ACTH independent Cushing syndrome can arise endogenously as well. In the setting of primary adrenal disease, the adrenal gland autonomously produces cortisol, regardless of ACTH activity. This occurs most commonly with a functional cortisol beaming, or blasting, spewing, constructing, casting, circulating? You pick. Adrenal adenoma, symbolized here by that plus sign lamp shining an eerie moon faced beam of light. Remember, think ad for adenoma. Rarely, adrenal carcinomas may be to blame for excess cortisol production. So we've also included that alien cancer crab. Remember, however, that most adrenal causes of ACTH independent Cushing syndrome are due to benign adenomas, not cancer. Micronodular adrenal hyperplasia and macronodular adrenal hyperplasia are the other primary adrenal diseases that can cause ACTH independent Cushing syndrome, but they are far less common and won't be covered in this sketch. Alright, now that we're oriented, we can see that glucocorticoid excess can be driven by elevated ACTH, or the glucocorticoids are elevated independent of ACTH activity. Next, let's talk about the presentation. Cushing syndrome presents with a wide range of signs and symptoms, many of which are nonspecific. This makes diagnosis challenging, particularly for milder cases. An important clinical clue is the simultaneous development and increasing severity of multiple symptoms. The most common feature is progressive central obesity. So, ask about recent weight gain. Seriously though? How did this guy even pass astronaut training? Make sure to ask about skin symptoms, as these are some of the most specific for Cushing's. Specifically, ask about easy bruising and any wide reddish purple streaks, known as striae, on the abdomen or lower flanks. Additionally, patients may report slow wound healing. These symptoms develop from the catabolic effect of cortisol on skin, which leads to thin and fragile skin with weak underlying connective tissue. Proximal muscle wasting and weakness is common and is one of the most specific symptoms of Cushing syndrome. This develops from the catabolic effect of cortisol, which leads to muscle atrophy. Patients often report difficulty climbing stairs and getting up from seated positions, or the inability to orient themselves in low gravity situations. High levels of cortisol impair calcium metabolism and alter bone homeostasis, leading to osteoporosis. Because of this, ask about a history of pathologic fractures at a relatively young age. Psychiatric symptoms are common, particularly depression. Patients can also develop insomnia, poor cognition, and even psychosis. Or in this guy's case, severe homesickness. Women with Cushing syndrome may report irregular menses. This is because hypercortisolemia suppresses secretion of GnRH by the hypothalamus. Women with some types of Cushing syndrome may develop signs of androgen excess because of oversecretion of adrenal androgens. In particular, women with adrenal carcinomas may develop hirsutism, acne, and virilization. Adrenal carcinomas secrete large amounts of androgens because they're inefficient at converting cholesterol to cortisol. So, next to that alien cancer crab, we've drawn in an astronaut brandishing our recurring androgen symbol. In contrast, adrenal adenomas do not secrete androgens. ACTH dependent Cushing syndrome, Cushing's disease, and ectopic ACTH may cause mild androgen excess. So, women may present with hirsutism and acne. However, androgen levels are not high enough to cause virilization. These symptoms do not occur in males because adrenal androgen production is dwarfed by testicular androgen production, even in the setting of adrenal carcinoma. Elevated cortisol alone does not cause hirsutism. Make sure to ask about any active glucocorticoid medications in all forms. Although we usually think of prednisone pills, keep in mind that glucocorticoid creams, inhalers, and injections can all cause Cushing syndrome too. Test questions will often be tricky and not specifically say that the patient is taking glucocorticoids. The question will instead mention conditions commonly treated with glucocorticoids, like rheumatologic diseases and obstructive lung disease with frequent exacerbations. So get that past medical history. Alright, time for vitals and physical exam. Cushing syndrome is a well known cause of secondary hypertension. It may be difficult to control despite multiple medications. The mechanism is multifactorial. Hypertension is most severe in patients with severe hypercortisolism, which is mainly seen in Cushing syndrome caused by ectopic ACTH secretion. In these patients, really high cortisol levels overwhelm the ability of the kidneys to convert cortisol to cortisone, allowing cortisol to activate the mineralocorticoid receptor. Activation leads to aldosterone like effects, such as salt retention and hypertension. On exam, look for central obesity, in which fat is disproportionately distributed to the face, neck, trunk, and abdomen. In contrast, the extremities may be wasted. Look for a classic rounded moon face as well. The neck may appear shortened and thickened from enlarged supraclavicular fat pads. Also look for a dorsocervical fat pad, classically described as a buffalo hump. Facial plethora is also characteristic. This is a sign of cortisol excess that you shouldn't expect to see in a patient with obesity and normal cortisol levels. Moving on. A thorough skin examination is critical. Look for large bruises, particularly at venipuncture sites, and make sure to examine the abdomen and flanks for those characteristic striae we described earlier. On skin exam, also look for cutaneous fungal infections on the trunk. Due to impaired immunity, patients are at increased risk for cutaneous fungal infections, particularly tinea versicolor. As with primary adrenal insufficiency, you may see hyperpigmentation in ACTH dependent Cushing syndrome due to the high levels of ACTH and therefore MSH, both of which are cleaved from the same molecule, POMC. Examine muscle bulk and strength, as patients often have proximal muscle atrophy leading to weakness. Over in the Moon Candy's lab, we can see that blood work may demonstrate hyperglycemia. Hyperglycemia occurs because cortisol stimulates gluconeogenesis and increases insulin resistance. As a result, patients are at increased risk of developing type 2 diabetes. And as you can tell by these wilting banana trees, in patients with really high levels of cortisol, such as those with ectopic ACTH secretion, hypokalemia develops due to activation of mineralocorticoid receptors in the kidneys. You know, the same sodium potassium exchangers involved in primary hyperaldosteronism. So let's summarize the typical presentation for Cushing syndrome. Sally Ride is a 42-year-old female who presents with weight gain and insomnia. She reports a 25-pound weight gain over 2 months despite dieting and exercise. Physical examination is notable for a blood pressure of 168 over 102 with facial plethora, central obesity, abdominal striae, and deltoid muscle wasting. I'm most concerned about Cushing syndrome. All right, let's get to the workup and management of Cushing syndrome. First, confirm that the patient is not on exogenous glucocorticoids. Again, don't forget to consider creams, inhalers, and injections. If the patient is on glucocorticoids, treatment involves discontinuing the medication. It's important to slowly taper the dose to prevent adrenal insufficiency. With the exception of cases caused by exogenous glucocorticoids, it's now time to objectively test for endogenous hypercortisolism. There are three major tests: late night salivary cortisol, 24-hour urinary free cortisol, and overnight low dose dexamethasone suppression. Let's start with late night salivary cortisol testing, which we're performing right now actually, over in the moon room. Here's the rationale. In healthy individuals, cortisol levels naturally reach a nadir in the evenings, but they remain abnormally elevated in patients with Cushing syndrome. Patients take the collection tubes home with them, collect a saliva sample around midnight, and bring it back to the lab in the morning. This test is the easiest and most convenient for patients. Alternatively, patients can collect 24 hours of urine to determine 24-hour urinary cortisol excretion. We are gathering this data over in the 24-hour sunroom. This accounts for episodic secretion of cortisol over an entire day. The test is abnormal if cortisol is greater than 3 times the upper limit of normal. Finally, low-dose dexamethasone suppression is the most well-known test, embodied by the astronaut here holding the index. That's dex for dexamethasone. She's kneeling too to represent low dose, 1 milligram in other words. In healthy individuals, 1 milligram of dexamethasone in the evening will suppress endogenous cortisol production due to appropriate feedback inhibition. In Cushing syndrome, feedback inhibition is impaired, so dexamethasone fails to suppress cortisol levels. This test is positive if the cortisol level in the morning after dexamethasone is greater than 1.8 micrograms per deciliter. As we described at the beginning of the sketch, before establishing the diagnosis of Cushing syndrome, physiologic hypercortisolism, also known as pseudo-Cushing syndrome, should be excluded. Physiologic hypercortisolism encompasses various conditions associated with baseline elevated levels of cortisol, like recent stress, such as illness, surgery, or trauma, chronic alcoholism, pregnancy, and severe depression. Physiologic hypercortisolism can sometimes present with clinical features of Cushing syndrome, but rarely has cutaneous or muscle involvement, and cortisol elevation is generally less severe than in true Cushing syndrome. The diagnosis is based on history and resolution of hypercortisolism once the stressor improves. Just let it melt away. The diagnosis of Cushing syndrome is established when 2 different hypercortisolism tests are abnormal, followed by the exclusion of physiologic hypercortisolism, which is why he's throwing up the peace sign. That's 2 fingers for 2 positive tests. If you have a high clinical suspicion for Cushing syndrome, order 2 tests right off the bat. If you have a low clinical suspicion for Cushing syndrome, only order 1 of the tests. Now that we've demonstrated that the patient has Cushing syndrome, the next step is to determine the cause. This is where we figure out what's responsible for all this excess cortisol. Start by measuring a plasma ACTH level. An inappropriately normal or high ACTH level means that we're dealing with ACTH-dependent Cushing syndrome. A pituitary adenoma or non-pituitary ectopic ACTH-producing tissue is making way too much ACTH, which tells the adrenal glands to make way too much cortisol. A low ACTH level means we're dealing with ACTH-independent Cushing syndrome. The adrenal glands are inappropriately and autonomously making way too much cortisol all by themselves. What happens if you get an intermediate ACTH level? It's not high or normal, but it's not super low either. Well, this usually indicates ACTH-dependent Cushing syndrome, but a positive CRH stimulation test may be helpful to confirm this. That's jumping ahead to step 2, though. So let's get to it. If our plasma ACTH level comes back inappropriately normal or high, and you suspect an ACTH-dependent Cushing syndrome, next we need to figure out the source of ACTH. Pituitary adenoma versus ectopic secretion. There are 2 endocrine biochemical tests that help us figure this out, and patients should undergo both tests because neither is perfect. The underlying principle here is that pituitary adenomas still respond partially to hormone suppression and stimulation, while ectopic ACTH producing tissues do not. These ROC indexes represent the results of a high dose dexamethasone suppression test. Patients take 8 milligrams of dexamethasone in the evening, and serum cortisol is measured the next morning. Expect a suppressed cortisol level in the setting of a pituitary adenoma, which is why this overexcited geologist is knocking over the moon camera next to our pituitary adenoma symbol. On the contrary, over on the right, the Cancer Crab rover is crushing that priceless index rock. In the setting of ectopic ACTH disease, due to small cell lung cancer, for example, cortisol will remain unsuppressed. The second test is a CRH stimulation test. In the setting of an ACTH producing pituitary adenoma, exogenously administered CRH causes ACTH and cortisol levels to rise, which is why this CRH camera tech on the left is supporting that moon camera and ACTH clapperboard. On the right, however, we can see that the CRH tech is getting run right over. Exogenously administered CRH does not cause ACTH and cortisol levels to rise appreciably when there's an ectopic source of ACTH secretion. If dexamethasone suppression or CRH stimulation test suggest a pituitary source, get a pituitary MRI to look for a pituitary adenoma. A lesion greater than 6 millimeters is considered clear evidence of an adenoma. If the pituitary MRI is unclear, either no lesion or a lesion less than 6 millimeters, perform inferior petrosal sinus sampling. A small catheter is advanced into the petrosal venous sinus, which drains the anterior pituitary. CRH is given to stimulate ACTH release. ACTH is then measured both from the peripheral blood and blood obtained centrally from the petrosal venous sinus. With ACTH producing pituitary adenomas, petrosal sinus ACTH levels are much higher than peripheral ACTH levels. In technical terms, a central to peripheral gradient of greater than 2 before CRH administration, or greater than 3 after CRH administration, supports a pituitary adenoma as the cause. Pituitary adenomas are treated with surgical resection, hence the scalpel shovel in the ground over here. Now, what if the patient has elevated ACTH, but with negative high dose dexamethasone suppression and negative CRH stimulation? This means that you're dealing with ectopic ACTH production from a tumor. The search for a tumor usually begins with CT scans, with contrast, although other imaging modalities, such as MRI, PET, or octreotide scintigraphy, may be necessary if CT is negative. Ectopic ACTH production should ideally be treated with resection of the culprit tissue and treatment of the cancer if applicable. Finally, let's head back to the last category of Cushing syndrome, ACTH independent disease. If the patient isn't on exogenous glucocorticoids, the pathology is at the level of the adrenal glands. In these patients, start with a CT of the adrenal glands. Adenomas are typically smaller than carcinomas. Necrosis, calcifications, or hemorrhage all suggest carcinoma. ACTH independent Cushing syndrome is usually treated with surgery. Adenomas are treated with unilateral adrenalectomy. Carcinomas are treated with surgical resection of the tumor. If the patient has adrenal hyperplasia, a much rarer etiology, treat with either bilateral adrenalectomy or medical therapy. Let's wrap up with medical therapy for Cushing syndrome. Surgical therapy is usually preferred because it can be curative. However, some patients are poor surgical candidates, don't have a good surgical target, or develop recurrence after surgery. Medical therapy inhibits adrenal cortisol production in order to control cortisol levels. Start with ketoconazole, represented by this pine cone key falling out of the astronaut's bag. This antifungal agent inhibits the first step of cortisol biosynthesis. The major side effect to watch out for is hepatotoxicity. Monitor cortisol levels during therapy with either morning cortisol checks or 24-hour urinary cortisol collections. If cortisol levels aren't controlled on ketoconazole, add metyrapone, symbolized by this metyrapone makeup kit. Metyrapone is an 11 beta hydroxylase inhibitor, which means that it inhibits the last step of cortisol biosynthesis. If cortisol levels do not normalize after treatment with ketoconazole, mitotane can also be added to reduce levels. Mitotane inhibits steroid production at the adrenal cortex, also exerting a cytotoxic effect on adrenal tissue. It's symbolized here by this cool mitotane mitosis logo. Also, Don't forget to treat the comorbid hypertension, hyperglycemia, and osteoporosis. These conditions will improve but may not normalize even after treatment of Cushing syndrome. All right, sum up time. Cushing syndrome presents with a wide range of symptoms, including central obesity, moon phases, purple striae, easy bruising, proximal muscle atrophy, fractures, depression, irregular menses, and hirsutism. Also, throw hypokalemia and hyperglycemia onto the list. The most common cause of Cushing syndrome is iatrogenic. This occurs in patients on exogenous glucocorticoids. ACTH will be low. Treat with glucocorticoid tapering. The diagnosis of Cushing syndrome is made when two of the following tests are positive: a late night salivary cortisol test, a 24-hour urine cortisol test, or a low dose dexamethasone suppression test. Also, rule out physiologic causes of hypercortisolism. Then, measure ACTH. Adrenal tumors will present with low ACTH and are primarily treated surgically. Females with adrenal carcinomas may present with signs and symptoms of androgen excess. Pituitary adenomas primarily occur in females aged 25 to 45. ACTH will be normal or high. Cortisol levels will respond to high dose dexamethasone suppression and CRH stimulation. Get an MRI. If you do petrosal sinus vein sampling, expect high levels of ACTH in those petrosals. First line therapy is surgery. Tumor production of ectopic ACTH occurs in older patients, usually greater than age 50, as this parallels increasing risk of small cell lung cancer and other neoplasms. ACTH will be normal or high. Cortisol levels will not respond to high dose dexamethasone suppression or CRH stimulation. Look for the source of ectopic ACTH. And of course, always remember, whenever those cortisol levels are rising, just hop into the cryo sleep chamber and let the cortisol melt away. Ah, yeah, just look at that guy. So peaceful.
Wake up! Wake up!
What? Huh? What year is it?
Talking apes are the dominant species and humans are being oppressed and enslaved.
What? What?
Just kidding. That's the plot to Soylent Green or whatever. Or was it Omega Man? Anywho, my turn. Yoink.
Seriously, what the